Welcome to the Beyond Pain podcast with your host, Joe Gambino and Joe LaVacca. Join the two Joes, two physical therapists, as they discuss how to navigate the uncertainties of pain so you can move beyond it and get back to the activities you love most. This podcast is for Joe, and their guests to share their clinical thoughts and ideas based on their collective clinical experiences. Can this information be for you? Maybe, but we cannot know for sure. Therefore, it is always worth talking to your healthcare provider to make the best decisions in your care before you implement anything on this podcast. And please use common sense. Welcome back into the Beyond Pain podcast. I am one of your hosts, Joe Gambino, and I'm here with your other host, Joe LaVacca. You can find us on Instagram. I'm at Joe Gambino DPT. LaVacca is at Strength and Motion _PT. You can find this podcast on Instagram as well, Beyond Pain Podcast, and on YouTube, Cups of Joe _PT. We are back. It has been one whole month since we've recorded, Joe, and yesterday marked the first NFL game. Did you watch it?
Of course. Well, I watched as much as, starting at 8:30 would allow me to. But yeah, we had a nice summer vacation. You were away. I was away.
Mm-hmm.
I had a very nice time up until about the last week. I would say I've been battling a little something since I came back from Europe. But your boy's going to be okay. I came ready, rocking for the podcast. Each day has been a little bit better. It's never fun to come back from vacation and then get hit with either food poisoning or some sort of stomach infection. And I sort of half expect it when I come back from places like Mexico and Cancun and, when I've gone down there. But then, coming back from France, I just wasn't expecting to be hit this hard. So, but I'm ready to go for the fall.
You sound good.
Yeah. I'm ready to go for the fall. I'm here. Was summer rewarding for you, Mr. Gambino?
Summer was good. Got a lot of sun, a few beach trips in, got, just in New York. It's still nice and warm here. Summer doesn't feel over for me. Got plenty of golf in. I think there's still going to be plenty of golf left for me to play this season. So we're good, and I'm excited for football. I got to watch a pretty good first half. Dak let me down. I have him in one of my fantasy leagues. He only got me like 7 points. So my my dislike for the Cowboys is starting to mount after that. It's not looking good for that. But yeah, man, I think it's been pretty good overall. And I think we have a very nice, fun topic here. It's something that I hear people talk a lot about. I think people, I'm not going to say anymore. Let's just kind of dive into really. We're talking about body sounds today, things like popping, clicking, things like that. So my first question for you, Joe, is when someone brings it up into you in clinic, how does that conversation go?
Well, I think most people start off with a little bit of concern, and it rightfully so. Typically, when people are reporting body sounds, it's going to be clicking or popping, maybe around the hip. We would even say that there's some clunking or shifting involved. And naturally, that makes them a little bit nervous. I do think that when we start to listen to their story or try to make sense of why they are here, not that I ignore it completely. And maybe that's where I've changed my stance over, the last few years or so. Because I did find that me simply saying, don't worry about it, just part of life, everything clicks and clunks and, makes noise and just groove with it and you'll be totally fine. Maybe a little bit invalidating, especially given the messages we've talked about here with listening and asking questions. So instead, I tried to rather understand a little bit more about what they thought. And most of the time, people relay it to maybe something unstable or something out of alignment. Now, those things for us in clinic might be a little bit more or less non-falsifiable. Like it's hard to really know if something's in alignment or maybe just kind of quote unquote out of place with the clinical tests that we can do. But I do think that noise or clicking and popping with motion probably would put me in the ballpark of thinking, okay, you're probably not here then for nerve pain. Tendons do click and pop and make some noise. So maybe we'd want to think about treating maybe more of a tendon here for you or some sort of tissue like that. And the other thing that makes noise are joints. So I'm probably thinking right off the bat that we can probably rule out the idea that this is some nerve entrapment type thing or radicular type pain that I'd be concerned about. And instead, maybe just kind of focus in on tendon and joint. So working that in with the client's story, if it does start to jive, then we can maybe make this clinical picture and say, hey, remember when you mentioned the clicking, the
Mhm.
popping, the this? Well, based on some of the things we talked about, what makes you feel better or worse, maybe this does make sense that it goes hand in hand with a tendinopathy or a sort of like joint condition. So I guess that's where I've been shifting a little bit more. How do you handle this virtually, especially? I'd like to know. And do you still stick with the old Joe that I was in terms of just completely being like, don't worry about
Yeah. Yeah, when they tell it to me, I just look them in the face and move on. I don't even acknowledge. No.
it?
Yeah, I mean, pretty much the way I look at it, I mean, depending on how I'm very similar. Depending on how they are telling their story and how concerning it seems to them will depend on how much of it I go into it with them, or how much I don't discredit it, but the way I educate it is that these things aren't things they're not traceable symptoms in a sense, right? They're not things that we're going to be directly working on. They are there. I acknowledge that they often feel uncomfortable to people. Like, people are like uneasy about it. They don't feel, it's not painful, but it doesn't feel great to them. So I acknowledge that for sure. And then switch the conversation to, and then I let them know, like, as like, whatever popped up in their assessment, as we start to clean this stuff up, what tends to happen is that noise that's happening tends to resolve itself. But if it does linger around, it's really not the end of the world. I mean, you're going to be able to do all the things that you wanted to do. I mean, almost, I'd probably say like 9 times out of 10, those things tend to resolve on their own. Oh, that's really kind of really how I go about it. So I let completely understanding and kind of empathetic and kind of reaffirm to them that yes, I understand that this is like in your, it's uncomfortable, right? You don't like it, you have this uneasy feeling about it, but at the same time, right, like that's not the thing that we're going to be going after, right? We're going to be going after, your lack of stability or your poor motion here or the ability, like you can't do X, Y, and Z. And as we start to clear these things up, we're going to start to see an improvement there.
Yeah, that's very interesting because the way you put it, I agree. I don't necessarily think we can treat the noise or the click. However, to your point, whatever we do in terms of treatment or exercise selection and become consistent, that click, like you said, does usually resolve. And then I think that kind of comes back and helps us with our initial stories. So, like you even mentioned and used the word stability. So, if there is maybe a little bit more of this tendon like clicking or joint or movement noise, I should say, then yeah, working on the coordination and timing and loading of the muscles and tendons should reduce that, right? The joint should probably move a little bit more freely or maybe not have that sound emerge for whatever reason. I usually attribute it to just kind of timing and coordination. And then secondarily with a joint, maybe that's a little bit harder to deduce like what the sound is, but more often than not, I'd probably attribute that joint noise to maybe more like swelling or fusion or fluid within the joint. And in which case, we know that joints make this wonderful fluid called synovial fluid every day. They sort of like turn over tiny amounts. Your bigger joints make more of it, your smaller joints a little bit more. But the best way to use that synovial fluid is with movement, right? What we preach all the time. And I sort of think like if tendons and muscles can help stabilize and learn better timing and coordination, and maybe that's why some of these sounds go away. What I sort of picture in a joint is we're using this nice kind of fresh olive oil every day that the joint makes, and we're flushing it around and we're pushing out old waste or maybe older fluid in the knee so that way it kind of bathes itself in all this new material. So I always come back to cooking because,
Hmm.
we're Italian. And I always think of it as like the beginning of your olive oil in the pan. Everything's all shiny and glowy. And then you throw some chicken cutlet on there. And after two or three, it's all sort of used up and gunky. And then you either got to clean it out or add some new olive oil. And then everything starts to churn over again. So that's what I think. I think I'm making chicken cutlets in everybody's joints by getting them to move a little bit more. And again, I think it just kind of helps us make sense, tells us the story. But I do agree with you. It does go away, it seems, or greatly reduces. And it's definitely not something that's going to deter me from loading or, potentially consider it a red flag where I'd want to send them out for more treatment or imaging. And does that seem to jive with, I think, what you're saying too?
Yeah, I definitely think it jobs and, chef LaVacca over there. I'm surprised you're not a bigger proponent of heat. So, but, I think where you just kind of brought up kind of led me to the next thing I think is kind of important to talk about is that when these sounds become problematic or when we would want to start to look at them more. So why don't we shift there? I'll let you kind of start.
I think that's good, and I was thinking the same thing that maybe some of these sounds, when we mix them with mechanical symptoms, to me would probably be maybe a little bit more, I don't know, alarming, but maybe more on my radar of let's pay attention to this and make sure it doesn't get any worse.
Mhm,
And this probably happens around, I would say maybe the hip, the shoulder, and the knee for the most part, where there might be this click or audible clunk or, joint noise. We can just kind of keep that big umbrella going. And then there's a lock associated with
mhm.
it at the joint. So the joint doesn't move for, a minute or two. You got to kind of wiggle out of it. If it's at the knee or maybe the hip, maybe people report that click or joint noise. And then the knee sort of like gives out or the hip sort of feels like it gives out on them. So I would say when we see these noises mixed with patching or locking and giving way, to me, again, that probably pushes me a little bit more to think about joint health. First and foremost, I want to make sure that the integrity for this person is there and make sure that they are going to be someone that I load or expect exercise to help. But that's going to probably pick up on my radar just a little bit more.
Now, just curious, like, if someone is getting kind of like a locking, are you sending them back to their doctor for stuff like that? Like the thing that pops out to me is locking, like bucket handle tears in the knee, right? Like there's usually ones that you may want to go get imaging on if you're suspecting it because they're just harder recoveries conservatively because there's something like in the joint that's stopping, the joint from moving in a sense. So where's your brain with that?
Yeah, I think it probably goes along the lines of their age, mechanism. If there was a trauma, I always tell people with trauma, it's probably to get at least a doc on board so
Hmm.
that they're following along with our case.
Hmm.
It's not that you have to decide against injection or surgery or
Sure.
anything like that, but if we do see you, we'll stick with the knee example, I guess, because you brought up bucket handle tear. You're out playing sports. We just brought up football. Hey, you got slide tackled. You felt a click, pop, snap, whatever. We don't think that there's any ACL laxity or something like that. So we do think there's a tear. Maybe the symptoms are lots of noise, instability. Hey, this happened very suddenly. So yes, I'd still always want to see where people can go conservatively over the maybe course of like
Hmm.
4 to 6 weeks minimum to make a decision. But I do always think it's probably worth to just introduce yourself to a doctor and be like, hey, look, this is what happened. This is what me and my PT think. I just want to sort of like get your opinion on, what does my recovery look like? What does expectations involve for me around this? What should I maybe look out for with my PT to judge progression? But at that time, what I'm doing with them is testing quad strength, testing hamstring strength, making sure that these muscles don't completely become inhibited or atrophied during the course of the rehab process. And if they're able to make just progressive functional gains, maybe I put them in a brace just to kind of help them out, which is either maybe signaling to everyone else in the New York City metro area, get away from me, give me your subway seat sort of thing. But I think it also kind of just gives them a little bit more of this joint awareness, having a brace or a sleeve there too, where they may be able to walk or move with a little bit more confidence. So I do think it depends. I know there's a really large study. Maybe we can re bring it up about meniscal treatments, tears, and managements that came out, I think, a couple months ago. So that might be fun to revisit in another podcast with everyone. I think for right now, mechanism of injury is always important to me. Age is always important to me. Mechanical symptoms are important to me. But then at the same time, I want to give it a little bit of time to just see where your body
Right.
goes and what you can do with it.
Yeah, I think, that also depends on how like, if it's very acute, I definitely wanna give it, you know, multiple weeks to see what happens because, I think what happens in an acute phase is you just really need to get past it to even know really what's going on around the joint before you can really poke and prod at it, before you can really start to load it, before you can, like, really get a good understanding of where that recovery is going to head. But I think, in the knee or anytime that there's locking, it always kind of puts a little, I wouldn't call it a red flag necessarily, but maybe like a yellow flag where I'm going to make sure we're watching and we're trending and we're making sure that rehab is going according to plan. Because otherwise, if it's not, and we're really not moving the needle in 4, 5, 6 weeks, like you said, then it's probably going to be, worthwhile to at least go get things checked out by a doctor just to make sure. And I always go to those things to rule things out as opposed to like, but yeah, you need to, go to figure out if you need a surgery or something like that. I think ruling things out just gives us more clarity in our journey and just not even just for us, like, hey, now we know, now we can just keep focusing on this. And we don't have to worry about like, if a flare up happens, right? Like, okay, we kind of like can stay the course now. We know a little bit more information, but I also think from a lot of the patient's perspective, it's helpful because once it gets ruled out, there's like a little, I think, anxiety kind of lifted off their shoulders. Like, oh, okay, I know my knee is clean. Maybe they're a little confused now why there's some pain, but I think it's better to be that way than it is to be the other way. I do want to bring one
Yeah.
more thing that I found interesting before you jump in, Joe. You talked about going to the doctor to, in essence, like bring them into the team and like, oh, yeah, you're just going to consult them. And I think that's a very interesting, and I don't think anyone, and I don't even think really myself has ever thought of it that way. Because people who go to the doctor, they don't go to consult the doctor and like bring them into the team and ask their opinion. They go there and they expect like, okay, well now you're fully in charge. Whatever you say is law,
Mhm.
and I have to now go do X, Y, and Z, and that trumps the physical therapist, that trumps the chiropractor, that trumps anybody else that they're working with. So it's a very interesting concept to go to your doctor and say, hey, listen, I'm not here for a whole lot except let you know what's going on, get your opinion so I can take this information and then with my team make a decision around it. And I just don't think people ever really have their brain wrapped in that direction. It's the opposite way. Like if you're with a doctor, you go talk to a PT or a chiro or massage therapist, get their opinion, and then you go back to your doctor, but it's never like the opposite way.
Right. I really think that patient advocacy or reading and pushing that idea a little bit more in recent years made me approach or say that. And maybe it's also the way I just view our profession is, or maybe the professions in general, is that there's not a hierarchy in medicine. There's just different fields and different people doing different things. So when I look at the landscape of healthcare, to me, it's just a landscape. And maybe even like the client kind of looking out in this landscape, determining like what path or what direction that I want to go. My opinion doesn't supersede a surgeon, and nor should a surgeon's opinion supersede mine, but I do think that there's different contexts to weigh where if I'm going to tell a person who has that bucket handle tear with mechanical issues and they're 22 and they're trying to get back to their football season, hey, there's no need for this. But then a doctor or a surgeon who is responsible for repairing the tear is saying, yeah, I understand you might not need it, but this is going to give you the best results you're looking for at this moment of time in your life. And I can do a lot more for you than, let's say, knee extensions or isometrics in PT for 12 weeks, which we still might end up back on the OR table as well. And then the same exact idea. Like if the surgeon then was like, okay, well, I want Joe to do squats and leg extensions and this, but don't stay away from deadlifts or this or that. It's like, well, doc, it's okay. Now I can take care of the
Mhm.
exercise and the rehab stuff because we just do different things. And I think when we shift that idea of like, well, I don't work for a surgeon any more than a surgeon works for me, but we both serve a patient,
Mhm.
that's where I think it makes a lot more sense for the patient to go in there with that mindset of like, hey, I'm trying to build a team. that helps get me to my goals. Will you be a part of that team? I don't know. This is an interview process. Like, do you fit my
Mhm.
goals? Do you fit my things? And what's reminded me of that even more recently was when Peter Attia reposted some of his conversation with Stu McGill
Mhm.
the other day. And I don't know if you caught that on the social
I didn't
media.
know.
And, everyone went into a frenzy when they heard this interview, probably about 6 months ago now, I guess it was. But it is interesting because in the clip that Peter reshared, Stu mentioned that he has a person in front of him and they come in with back pain and their goals are, I want to deadlift and I want to get stronger. And then Stu's response was, well, hold on, let me give you this scenario. Do you want to deadlift or do you want to play with your grandkids, when you get older? And
I
to
saw
me,
the
it's like,
original.
yeah, exactly. And to me, that's the complete opposite of what we're saying here. Then for someone like that, Stu McGill probably doesn't deserve to be on your team. And that's also okay, right? So Stu has a mindset or a way of doing things. So when people come and seek Stu's advice, you probably want to be aligned with the way that Stu
Mhm.
thinks. You probably want to be aligned with the way I think and the way you think to have the most successful outcome. But to think that any one of us has the right answer, well, then what the hell else are the rest of us doing if one person has already figured it out? We should all just be doing that. And I think it gets to
Yeah.
be a lot more complicated.
Yeah, no, I really like the idea here, and I know people who are very much like that, where they will shop around, they will find the doctors that fit who they are, their goals, who will be more collaborative and part of a team. But I don't think that's the norm by any means. And I think that most people, they don't do any shopping around, not even for physical therapists, not for the doctors, not for the chiros, not for anybody. It's more based off of convenience. Is who's closest to where I live and who's in my insurance-based network. And if you meet those two things, you're going to go see that doctor, whether or not you've had a good experience or not. And that seems to be, the most common scenarios that I see. So I definitely think that if you're listening to this podcast, that changing your mindset, if it is of that, especially if you've been dealing with pain for a while and you're trying to figure out, you've seen multiple doctors, maybe you just haven't done enough shopping around and finding the people who need to be on your team as opposed to the people who are just closest to you. Or maybe you've seen a doctor and you kind of like them, but you haven't seen results for a while. Maybe it's time to go interview some new doctors, PTs, chiros, to find a team that's better suited for you, or maybe will move you one more step forward in your journey on whatever goals that you have. So I think that's definitely an interesting thought process, and I've thought about that particularly before, and I just think that people listening should definitely start considering that if it makes sense for them.
Yeah, and this is where I think the beauty of virtual medicine and telehealth, which we've talked about and will continue to talk about, gives you more of those
Hmm.
options, right? It expands your supermarket. And just before our podcast, I got off a virtual appointment with a client of mine in Wisconsin. And he was telling me how the nearest doctor is about an hour away. The nearest PT is like 45 minutes in the other direction
Hmm.
from where the doctor is. So, there's more or less options I understand based on where you live.
Sure.
And from where we were in New York City, and I'm sure even where you are now, when people look at a provider in network, you still have hundreds and hundreds of options next to your work, next to where you
Hmm.
live, or next to your kid's school. And that's sort of like the benefit of being in maybe one of these like higher population zones. But by no means do you have to settle if if you're living in, Wisconsin, next to this nice quiet river in a nice
Hmm.
wooded town, because now as long as you have an internet connection, you can start to search and do a little bit more of your due diligence as well. And then, you know, we talk about the benefits of virtual all the time and how wonderful they are. And I absolutely do not think or perceive there has been any difference in results for my virtual clients or in person clients, which is what makes me, again, me more and more excited about the future.
Yeah, no, I like that. And maybe I know we've gotten a little bit off topic from the body sounds, but I think this is maybe an important question for the listeners, because I have, I think a common question I get is, well, I don't really know what to look for or what to ask to figure out if someone fits the bill. So if Joe LaVacca was going to a physio, a chiro, PCP, to what kind of questions, what are you looking for? What kind of things should listeners look out for when trying to select a provider for them?
Well, we've talked about listening being probably the most important
Mhm,
thing. So, regardless of who you go see, if they're not willing to just sit down and listen to your concerns and your questions, then immediately that's not the person for you. From there, I think that you just want to ask questions about what your values are. So, to me, my values are specifically around exercise and around movement. So if I had we can just stick with the knee injury again, because that's the example we've been using. If I have a bucket handle tear in my knee, I want to know what this doctor thinks about exercise management. I want to know what he thinks about conservative care. I want to know what he thinks about the opportunity or the likelihood about avoiding surgery or the actual skills that he has. Because I think with someone like a surgeon, too, all of these decisions are very final. Someone could come in and see you or me and be like, Joe's not really for me, or maybe the virtual experience is not really for me. So I'm just going to pivot. And there's no issue with that. In your care, your knee doesn't care, and your life goes on. But if you go into a surgery or something like that invasive, there's no going back from that.
mhm,
That's it. That decision has been made. Listening to me is always number one. And then it really comes down to individual values. What is important to you?
mhm,
How likely is it does your doctor think that you could be successful in this process? What are the options in this process aside from surgery? And I typically always encourage people to ask about their outcomes because I have data on it. You have data on it. All we have to do is go into our journal article research databases and look at the outcomes for sciatica and
sure,
realize that, a year later, everyone's about the same. Look at the outcomes for a lot of meniscal surgeries versus people who don't. And about a year later, everyone's about the same. And the list goes on with like rotator cuff and on and on. So if where I'm going to be is the same with or without the surgery, why would someone like me need this treatment? And I think that's really the sort of like guidance and
mhm.
decision making that people should really be interested in.
Yeah, I like that. I think the only things I'd add there is, I think listening is definitely a big one, but I feel like at the end of the day, regardless of the provider, you should feel like you were valued at the end of that
Hmm.
session. Too many times have I heard, I was just passed off or I was in there for 2 seconds and they did one, two, or three things and I was out the door. So I think if you're feeling valued, you feel like you had a good experience, they took time to ask you questions and understand your goals and listen to your side of the story, I think you're probably going to be in the right track for having a provider for you. And then just from a movement based perspective, I think the only other thing to add there is that you're being challenged. You know, if you're going to anywhere, and obviously a doctor, you can't be challenged. Maybe question wise you could be, but if you're seeing a chiro, PT, something like that, and your exercises are very easy, you're not challenged, and your goal is to say like go running again or play more golf, and like you're just on a table and you feel like you've done nothing at the end of it, then you may want to reevaluate a little bit because rehab, especially when you have higher level goals, should start to slowly, right, increase in intensity so that it can help you actually do those things. So that's probably the only little things I would add here.
Yeah. Well, just to close on our original point, like the joint noises and then mechanical things, have you had anyone recently where has either sort of like heeded your advice and was like, hey, this is okay, and then stuck to some conservative care and totally fine? Or, maybe the other direction, tried to heed the advice and then you guys had to make a decision and then how did surgery come out? Anything like that recently for you?
Recently, not where someone was like, "Ah, this hasn't worked and needed a surgery." I think I've had, I'm trying to think back on times. I've had people in the past who, I gave my advice and they just opted in for surgery regardless, and that's perfectly fine, right? That's your decision making process between me, what we've talked about with your doctor, and then what you want to do and your beliefs and things like that. I've had those things pop up for sure. But recently I haven't had anything where it was, they had to go to the doctor and ended up down for a surgery. I don't know if that, have you had anything
Well,
down
I
that
think,
route?
the things that I'm always reminded of is probably more patient failures
Mhm.
than anything else, right? But it goes back to that idea of like what you said, like being validated and being heard. And if someone truly believes that their noise or clicking and popping and instability is incurable, or they don't think they will get better, and then they find a surgeon that's like, well, yeah, you're 100% right. Like, this is all out of alignment. This is torn. This is this. I can stabilize this. I can do that. Well, now, why wouldn't I listen to that? That's a way easier outcome than what Joe's saying is like, well, maybe it'll get better in 6 months. And then by 12 months, you'll probably have a really good chance of being better. When this doctor said, why wait that long? I can get you better in 2 days or 3 days or 4 days. But again, I think, like you said, it's when that person does feel more maybe validated or heard, even if it's what they want to hear, that's going to really factor into
Mhm.
some decision making. And, like I say to them, if you get the surgery, that's fine. Yeah, we know that there's some likelihood of you getting more arthritis in the future, maybe having some more complications in the future, but that's right now. With the way that medicine changes, who knows? Maybe there's a nice new pill that comes out that regrows your cartilage in 6 months. Maybe there's a new injection in 2 years that can do the same thing. So, I think that we maybe sometimes as rehab professionals fail to think that the data I'm looking at right now is probably not going to be the data in the next like 6, 12, whatever years. And there's probably going to be a lot more adjunctive therapies to help people who've had these surgeries maybe fully recover. And then we can kind of lower that. And then we lower suffering right off the bat. And then, maybe we're all holding hands in that whole healthcare landscape, singing kumbaya, that we're on the same page and we all do the same thing. So maybe, who knows? I'm not sure.
And listen, in 10 years, we're all going to just be living in a world just out of our consciousness. Like, we're not even going to need our bodies anymore. So, you know, just hold off 10 more years and
That could
you'll
also
be.
be it too, right? So who cares if I get knee surgery now? I'm not going to need it in the metaverse.
But I do want to do one little close here just to loop back. We've kind of looped back already, but takeaways for people listening. One, I mean, we've talked about it before. Pain doesn't equal damage, and neither does, kind of clicking or noise or anything like that. So just keep that in the back of your mind, regardless of, hopefully that helps you in some way, shape, or form. And then if clicking and pain are together, I mean, that's when they become symptoms to start to try to improve, right? Because the whole point of all this stuff, right, is to improve pain. And again, right, like I think when we talk about pain, we don't always just like, hey, your pain is in your knee, so we have to like treat your knee, right? We look around and see what's maybe causing their pain, and sometimes the side of pain isn't always the area that's the root cause, so to speak. So couple things to keep in mind as you're kind of going through it, and then always just kind of give yourself a buffer to see if the needle can be moved 4 or 6 weeks with whatever you're going to try, and if there's no change, then I think a reevaluation process should have to happen for that person, because you shouldn't see no change in a certain period of time. You can still have pain, but maybe the intensity is less, the frequency is less. You can do a little bit more. Something should have changed positively for you in that time.
I agree.
Anything left for you, Joe?
No, I think it's been nice to be back. I feel
Yeah.
whole again. And I'm looking forward to the fall and beyond. We'll get some new guests lined up. So, listeners, if you're out there, lots of fun things coming on the Beyond Pain podcast. I look forward to being there with you and Joe. I love you. Listeners, we love you. And don't forget to come back for another exciting episode of the Beyond Pain podcast.